Yeah, today I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Shomshekhar, to start this session. Welcome, sir. Over to you.
Thank you very much, Navneet Singh ji. Dear trainees, what I have decided is for next 2 months, 2 months, block of 2 months, I will take each organ and systematically we cover it. And we know that Dr. Saurabh, an excellent surgeon, Uro-onco trained. Last time he covered the bladder tumor for us, so I requested him to cover the renal tumors today. So that way, what happens is maybe after some time, I'll again request him to cover testicular tumor at some time. So the three most important tumors, and prostate was covered by Dr. Vinayak Maka, because nowadays the prostatic part is predominantly become medical oncology. The BRCA gene and then the multiple hormone manipulation available, the whole treatment has changed. So organ wise, I thought we'll cover. Then I will cover the whole thoracic oncology, then head and neck oncology. So in 8 to 9 sessions. I welcome Dr. Saurabh, my dear friend, an excellent surgeon and very well learned, and he reads a lot of clinical trials in between the line, interprets them and assimilates them. Always there to help me when I need help to train the students. Thank you very much, Saurabh. He's a very senior urologist and uro-onco at Manipal Comprehensive Cancer Center, Manipal Group of Hospitals. And he has done a fellowship in Rajiv Gandhi in uro-onco and very well trained both in robotic, open, and all aspects of surgeries. Thank you very much, and over to you, Saurabh. And trainees, please put all your doubts and questions in chat box and Q&A. At the end of the talk, Dr. Saurabh will open, read, and in the given time, he will try to answer all of them. Thank you, and welcome, Saurabh. Over to you.
Thank you, sir. Thank you. So, good morning, everybody. So, today, as Dr. Somshekhar has already explained, that we will going to talk about the approach to the renal mass. So, again, like the way we have started last time, we're going to start. So, whenever the patient is coming to us, when and how to suspect. So, whenever somebody is coming to us with complaining of painless gross hematuria or persistent and recurrent unexplained microscopic hematuria, flank pain with hematuria, any hypoechoic mass lesion on the ultrasound, any complex renal cyst in the ultrasound, any mass lesion in the kidney with the calcification, any unexplained loss of weight or loss of appetite, any unexplained fever, which is a manifestation, paraneoplastic manifestation of RCC, and it is classically known as picket fence pattern, and symptoms secondary to local, regional, or distant spread like nerve compression, organ compression, focal neurological deficit. If any patient is having history of smoking, tobacco, and hypertension, and last but not the least is the feature suggestive of hereditary syndromes like VHL, tuberous sclerosis, or MEN. These are the patients whenever they are coming to your OPD, and you should always have a high suspicion to rule out the malignancy, and especially the renal malignancy. So basically, what are the risk factors? So there are only 3 established risk factors, apart from others which are not very well established. One is obesity, hypertension, tobacco and smoking consumption, and if there is a family history of hereditary syndromes. Now, what are the things to be taken in the history and examination? So whenever somebody is coming to us, or whether we are having a suspicion of RCC, we should always look at history of smoking, tobacco, hypertension, whether there is any episode of gross or microscopic hematuria, any flank pain, any unexplained loss of appetite or loss of weight, any jaundice, which may be suggestive of liver mets, any cough, which may be suggestive of any lung mets, and recent onset of exoskeletal pain. In this history, I would just like to tell you about 2 main important things. One is pain, and one is recent onset of exoskeletal bone pain. So flank pain will going to happen only in 2 conditions. Either there is an obstruction to the PCS leading to the hydronephrosis, or there is a extension of the malignancy to the perinephric nerve space, nerve bundles. And in both the conditions, it is highly suggestive of locally advanced malignancy. So whenever the patient is coming with the pain, we should know that we are treating the patient in a locally advanced disease, and the prognosis may not be as good as this. And in the bone pain, if anybody is complaining of joint pain, will not be considered so significant. But yes, if anybody complaining of exoskeletal bone pain, it is highly important to rule out the possibility of any bone mets in this condition. In examination, what we have to see in the general physical examination, we have to look for the pallor, we have to see the icterus, we have to see for the left supraclavicular lymph nodes, we have to see the inguinal lymph nodes, we have to see the lower limb swelling, because sometimes either because of the IVC thrombus or large retroperitoneal nodes, there is a possibility that patient can have lower limb swelling, either unilateral or bilateral. On examination, we should rule out any palpable renal mass or abdominal veins. Again, these are the findings which are highly suggestive of locally advanced disease, and we should prepare our mind accordingly. And in the local examine, in the external genitalia, the most important thing is the varicocele, and mostly it is more common on the left side rather than on the right side, because the left gonadal vein opens into the renal vein. So whenever there is any varicocele, we should always try to rule out the possibility of any renal vein or IVC thrombus. And if the patient is male, then in all the patients above 40 years, you should always do the DRE, because there are cases when you can have simultaneous two things, the CA prostate as well as RCC. So the clinical presentation, nowadays with the advent of imaging and health checks, most of the time RCCs are incidental, and overall patients, 60% are incidentally reported. Out of that, stage 1A patients are 87% are incidentally detected, and 36% of patients are incidentally detected in stage 3 and stage 4 also. Now, about the locally advanced disease, the classical triad of the flank pain, visible hematuria, and palpable abdominal mass is very rare nowadays because of the regular health checks and extensive imaging nowadays. So whenever you are finding, it is very difficult or rare to see this triad nowadays, but whenever you are finding it, always have a high suspicion that you are dealing with either locally advanced or metastatic disease. And it always correlates with aggressive histology, advanced disease, and poorer outcome. Now, some patient can only present with the paraneoplastic syndrome. Paraneoplastic syndrome can vary right from the polycythemia vera, Stoffer syndrome, anemia, fever, hypercalcemia. So how to define paraneoplastic syndrome? So it is the other systemic symptoms which cannot be explained by the RCC directly. So mainly they are because of some hormonal or some chemical changes due to the RCC, and which lead to these symptoms. And most of the time it has been identified that as soon as you will going to treat the primary tumor, the paraneoplastic syndrome will revert or normalize. And in the metastatic presentation, patient can have a focal neurological deficit, he can have a bone pain, he can have cough, he can have nerve compression or compression to the adjacent organs. Now, how to evaluate the patient? So whenever somebody is coming to the OPD and you have a high suspicion of RCC, you should have some basic evaluation first, which will going to give you an idea and lead that how to proceed further. So you should have an urine RM, routine microscopy, where you have to see the RBC. Here, what is more important, that it should be a routine microscopy, not the dipstick, because dipstick can falsely detect the hemoglobinuria or myoglobinuria also as a presence of RBC. Presence of blood. But if there is no RBC on routine microscopy, we should not consider that as a positive for the hematuria. We should always have a serum creatinine straight away, because it will going to give us an idea that which investigation we should offer to the patient. We should have an ultrasound KUB. We should have Euroflow if there is an associated lower urinary tract symptoms, and if PSA if there is an abnormal DRE or any other indication. Ultrasound, what we have to see in ultrasound, we have to see that whether there is any mass lesion, whether that mass is solid or cystic. If it is a solid mass, whether it is a hypoechoic mass, hyperechoic or heteroechoic. So usually it has been found that the hypoechoic or heteroechoic masses are highly suggestive of some malignancy. Now, once you confirm that there is some renal mass or some complex cyst, then we should go for the detailed workup, which includes metastatic evaluation, and it includes imaging as well as blood investigation. So in blood investigation, you should have a complete blood count, because it will going to give you an idea about the anemia and any paraneoplastic syndromes. And nowadays, the CBC is also a very important part of the risk stratification in RCC, which will going to give us an idea that in which risk category the patient is. We should have a renal function test. We should have a LFT. In LFT, what is the most important thing? You have to see the serum bilirubin, which will going to give you an indirect evidence of any liver mets. You have to see the enzymes, which will going to give you and rule out the possibility of paraneoplastic Stoffer syndrome. You should have an alkaline phosphatase, which will going to give you a subtle finding, which will going to be high in cases of bony metastasis. And you should have an LDH level, which will going to give you an idea that what is the extent of the disease burden. You should have a serum calcium because again it will going to give you an idea either about the metastasis or the paraneoplastic manifestation. And never forget to have an X-ray chest because it is a very mandatory part. Now, once we will going to have this, we will going to have a basic idea now how to proceed, which imaging should be done. So whenever we are having high suspicion of malignancy, we should always have some cross-sectional imaging. So usually it is said that there is no role of plain CT or MRI. So when to do the CT? In ideally all the condition, if there is no specific contraindication to do the CT, patient should always offer a contrast enhanced CT scan. And what to see in this? We have to see either the enhancement of the mass, or if in case we don't have the arterial phase available with us, then we have to see the de-enhancement. And what is the value? Usually it is said that if there is an enhancement or de-enhancement of 15 to 20 Hounsfield unit, then it is highly significant and it is very much suggestive of any malignancy. The other thing which we can see in the CT scan is the extent, the lymph node and the any thrombus. Initially, it was thought that the MRI is better for the assessment of the thrombus extent, but nowadays with the multi-detector CT, 128 slice CT, the current CT scans are equivalent to the MRI, and there is no specific indication of doing MRI to assess the extent of the tumor thrombus. However, MRI is a very good modality to comment over the invasion of the IVC wall. So whenever there is any suspicion of invasion of IVC wall, we should go for the MRI also. Otherwise, CT scan is enough. Now, when to go for the MRI, it is very, very good for the cyst characterization. Whenever there is a complex cyst, initially the classical cyst characterized Bosniak cyst classification was based on the CT scan, but there is a recent change in the cyst classification, and it has been now based upon the MRI. So it is said that it is better to go for the MRI rather than CT scan whenever you are having a cyst evaluation. If there is any specific contraindication of doing CT, like serum creatinine is high, more than 1.5, and you can safely go for the contrast MRI from 2.5 to 3 creatinine. That is, GFR should not be less than 30. However, beyond above serum creatinine of 3 or GFR less than 30, we should always avoid giving a contrast because it can lead to a irreversible damage that is known as nephrogenic systemic fibrosis. Again, as I've explained you, MRI is equally good as CT scan, but yes, if you are having suspicion of IVC wall invasion, then it is always better to for the MRI. Now, about the PET CT or PET MRI, because of the poor avidity of the FDG, avidity of the RCC, and because of the presence of the large renal mass in the vicinity of the great vessels, which will going to have the FDG uptake or FDG lightening up, it is very difficult to comment over the loco-regional spread of the malignancy on the basis of PET CT. So ideally, there is no role of initial assessment. However, it can be utilized very well if there is an equivocal finding on CT and MRI, if you want to have a post-treatment assessment, and if you want to have the follow-up of the patient, or if we have a high suspicion of distant metastasis, and if you want to have a documentary evidence and confirmation of that. Normally, the FDG avidity is very poor for the classical RCC, and ideally it should be the best PET CT ligand is the carbonic anhydrase 9 ligand for that, because it is an enzyme which is present in the proximal tubule and which is the site of histopathological origin of the RCC, but unfortunately it is not available in India. The sensitivity of carbonic anhydrase ligand PET CT is up to a tune of 90%. Now, when to go for the bone scan? Usually, unless there is a high alkaline phosphatase or there is a bony pain, recent onset of bony axilloskeletal bone pain, very much suggestive of bony metastasis, then only you should go for the bone scan. Now, is there any role of contrast USG? Yes, if the patient is not fit for any contrast imaging like CT or MRI because of the renal function and other issues, then in those conditions, there are studies when they have said that the contrast USG can also give us an idea. Now, when to go for the CT, brain or MRI, it should be done offered only if there is a focal neurological deficit or high suspicion of any brain mets. Now, when to go for the CT thorax, usually it is said that unless there is some chest related symptoms like chronic cough, if there is an abnormality detected on X-ray chest, or if the large renal mass beyond T3 or large retroperitoneal lymph node, then only in these conditions CT thorax should be offered. Otherwise, there is no rule of getting a CT thorax because it will going to unnecessarily detect some non-significant nodule and other things which will going to further create a confusion and will require an additional imaging or additional evaluation to rule out the metastasis. Now, venography, it is a investigation of old time when there was no MRI available, so they used to do the venography to assess the thrombus extent and invasion. Now, the transesophageal echo is usually done during the intra period to assess any thrombus or to assess the extension of the intracardiac extent of the thrombus. Now, the renal scoring system. So why it is important? So usually, as we know that in the past, the only answer for any kidney cancer was radical nephrectomy. But then gradually, it has been found that those who have been offered the radical nephrectomy, especially for the small masses, they have high chances of CKD progression and cardiovascular morbidity. So there was a need to comment over this to identify some system by which we can predict or we can understand that which patients are suitable for the partial nephrectomy or which patients can be safely offered partial nephrectomy without unnecessary additional complications. So there are certain scoring system has been devised. The most common and most widely used is the renal scoring system, where there is a 3-point system which gives you the maximum diameter of the tumor, exophytic or endophytic nature, nearness of the sinus or the collecting system, anterior, posterior, and location. And by that, you can give a scoring system. There are other scoring systems based upon some shortcoming of the previous one, like in renal system, there was no comment over the PCS or renal sinus fat invasion. So they have come with the other scoring system like Padua scoring system, C-index, centrality index, zonal nephro system. I just want to say that among all these nephro scoring system, the only purpose of doing these nephro scoring system is to predict the possible outcome. It should not direct the decision of partial nephrectomy or radical nephrectomy. There is a head-to-head trial where the blind trial, double-blind trial has been done when the clinician has been offered CT scan directly without nephroscoring system, and when the clinician has been offered CT scan with the nephroscoring system, and in both the condition, up to 80% cases, that there was no change in treatment plan. So basically, this scoring system is meant to predict the complication and to standardize while writing the papers, so that we can very well communicate between the clinicians or between the doctors, so that which kind of tumor we are dealing with and what is the possibility. The most common reason of the complications are mainly because of the injury to the vessel or injury to the PCS or the loss of renal parenchyma. So among all these, there's a very sensitive index, is the C-index, which actually gives you an idea that how much percentage of the tumor is in the contact surface with the normal renal parenchyma. So in this, we have found that there is a possibility that at 8 centimeter tumor, which is mainly exophytic and not an endophytic, will going to have a less complication rather than doing an 3 centimeter totally endophytic tumor, because it is totally surrounded by the normal renal parenchyma. So basically, it is for the standardization purpose. Now, one talk about the Bosniak classification. So basically, whenever we are having an ultrasound and we found the cyst, so how to identify? So the cyst mainly has been defined in the 5 category. The Bosniak type 1, when it is a simple cyst, when there is a hairline, thin septa, thin wall, without septa, without calcification, without solid component. Now, one important factor why it is important to differentiate these between these cysts, because number one, ultrasound can only tell you whether it's a type 1 cyst or rest other cyst. So whenever we have to define these cyst classification, it has to be defined on the basis of either CT or MRI. It should not be defined on the basis of ultrasound, because ultrasound is an operator dependent investigation. And why it is important to differentiate, because it is going to give us an idea that what is the future possibility of having malignancy. So as we say that the type 1 and type 2 are usually benign cysts, so there is in type 1 there is almost no possibility of having future malignancy. In type 2, less than 5% chances of having malignancy. So in these conditions, patient does not require any repeated follow-up ultrasound or any CT at present. In type 2, the septa is also, so there are hairline thin septa, very fine calcification, and usually it has been found that the size is less than 3 centimeters. But in some cases, when everything is there, and the most important that there is no enhancement. But when the same findings with the minimal enhancement, or when the septa become little thick, or the size become more than 3 centimeter, then in that condition we say that it's a type 2F cyst. And why it is important? Because it is having little extra chances of having progression to malignancy, and these are the patients we should always offer a regular follow. In type 3, the septas are little thick. There is a nodularity and there is an enhancement. Now, so how to differentiate? So for in type 1 and type 2, there is no enhancement. So they are totally benign and does not require any treatment or follow-up. From type 2F onwards, the difference is the thickness of the septa and the enhancement. And the type 2F is usually having around 5 to 10% chances of future malignancy. So they require a regular follow-up. In type 3, it is a thick irregular wall with septa with enhancement, and it is having around up to 50% chances of future malignancy, so they should require an active surgical management. And whenever you are offering surgery to these patients, you should always tell them that we are not doing this surgery because you are currently having malignancy. We are doing it because there is a possibility of future malignancy. So in these conditions, sometimes the biopsy comes benign and the patient can argue with you that why you have offered it. So, and in type 4, it is almost 100% chances of malignancy. Recently, the Bosniak cyst classification has been revised. Initially, it was defined on the basis of CT only, but now they have included the MRI also. So in the CT, type 1 is well-defined, thin, smooth wall, may or may not, very less enhancement, and MRI is also the same. In type 2, there are six types, so there are no enhancement or very little enhancement, and the septas are very thin, the calcification is very thin. And in these conditions, that there are now in MRI, what they have done, that instead of just talking about the septa, they have also talked about the number of the septa and what is the kind of the septa, whether this angle is having acute angle or obtuse angle. So in type 2F, it is just like that cystic mass with minimal thickened 3 mm up to 3 mm. Initially, there is no thickness defined, how much thickness we have to see. And there is a number. So if it is more than 4 or smooth and less than 3 and enhancing, then we should consider it as a 2F thing. And this MRI is also seen. Now in type 3 cyst, 1 or more enhancing or thick septa, which is more than 4 mm in the thickness. Initially, there was nothing described about the thickness, and the same. And in the type 4, it is the more than 4 mm thick or the nodular enhancement. So this is the new thing which has come in the type 1. The wall thickness should be less than 2 mm. In type 2, it should be less than 2 mm, but from type 2 off onward, it should be 3 mm or more than 4 mm. Septa number, if there is no septa, then it is type 1. Up to 3, it is type 2, and beyond 4, it is type F. Now, enhancing pattern, usually there is smooth enhancement, no enhancement septa. Here, the septal thickness is less than 2, 3, and 4. Irregular, if it is irregular, then it has to be classified as 3 and 4 only. And enhancing nodule is very much classical of. So that is why it is important to redefine nowadays. Now about the staging system, there is a AJCC 2017 classification which defined it T1A up less than 4 centimeter, T1B 4 to 7, T2 7 to 10, T2B more than 10. Now what is the major difference between the T3? Initially, they were not considering about the level of the thrombus in the staging. So all tumor thrombus, whether it is level 1, level 2, level 3, whether it is with IVC wall invasion or without IVC wall invasion, everything was included in the T3 staging. But later on, it has been identified that those tumors which are having IVC invasion has poorer outcomes. So they have redefined it, and now it has like this. The T3A includes if it is the tumor thrombus is extending into the renal vein or subsegmental vessels, or it invades the PCS, or it invades the perirenal or sinus fat, but not beyond the gyrotas fascia. In T3B, the tumor thrombus is usually below the diaphragm, that is level 2 or level 3 thrombus. In T3C, either it is a level tumor thrombus above the diaphragm or with the invasion of the vena cava wall. Initially, this thing was not available in the previous TNM classification. Sometimes there are short notes there which ask about the difference between the old and the recent TNM classification, and this is the same. T4 is same as there. Only difference is this, that initially the ipsilateral adrenal gland invasion was considered as a metastatic thing, but now it has been redefined as a T4, especially if it is in contiguous extension. But if it is a non-contiguous extension, that means if the major renal mass is in the lower pole and the adrenal is positive, then again we have to consider it as a metastatic invasion. But if it is a tumor of the upper pole and invasion with the invasion in the adrenal, then it should be defined as a T4. Now, if there is no lymph node, it is N0. If there is a lymph node, then it is N1. Now, the summary, how to go for that, as I have explained to you, the CT scan or MRI has to be done. MRI is again very sensitive for cystic renal mass assessment. Contrast enhanced ultrasound can be offered only if it is other things are not available. So now these are the recommendations what required, and as I have explained to you, CT scan, and when we can omit the CT scan, when to offer this, when to do the bone scan, when to do the PET CT, whether we should go for the biopsy or not. That I will go to discuss in other slides. So this is the summary and evidences, like in hereditary cancers, what to do and how we should, when we should suspect. So if the tumor patient is less than 46 years, having bilateral or multifocal tumor, or with the history of first or second degree of RCC and close blood relative, these are the patients where we should suspect an hereditary tumor. And why it is important to understand about the hereditary tumor, you should not only offer the genetic workup, but there is also a treatment strategy different in cases of hereditary tumor that I will discuss in the slides of the management. So now about the pathology, as we know that classically the RCC is defined as clear cell RCC, but recently the other variant has also, other types of RCC has also been defined. And why it is important to differentiate between the classical and other, because the prognosis is different and sometimes even the treatment approach is different. Usually it is said that the partial nephrectomy should be reserved only up to the clear cell, papillary cell, or some chromophore tumors only. Beyond that, if any other things like renal cell medullary carcinoma, tuberocystic, collecting duct, translocation type, mucinous, they all should be mainly offered aggressive surgery, or they should be considered for the radical nephrectomy. And these are the one of the indication when you may have to convert to the completion nephrectomy in the post-op also. So these are the different varieties like clear cell, papillary, hereditary, tuberocystic, succinate. So they all are basically to differentiate that which kind of, what should be the treatment philosophy and how to offer the treatment to the patient. So again, this is the summary which I have told you, that in type 3 cyst, we have to consider the active surveillance or the treatment. In AML, what to be do? So if the AML is large, then in cases of large AML, in cases of female with childbearing age group, or when there is a chances of symptomatic, we should always offer the surgical treatment to these patients. Now, as we know that whenever somebody is having suspicion of malignancy, it is a rule that we should always prove it, that whether there is a malignancy or not. But RCC is one of the exception, and usually it is said that the sensitivity of the CT and MRI is more than 80%. And so because of this high sensitivity, usually it is said that there is no need for biopsy and you should not offer, because even a negative biopsy with a very high suspicion of malignancy will not going to change your treatment plan. So in these conditions, when to offer the biopsy to the patient, or sometimes even patient may ask you. So whenever there is a suspicion of infective pathology or lymphoma, when there is an bilateral homogeneous enhancement, enlargement, homogeneously enlarged kidney, whenever we are planning for any renal preservation or treatment like RFA or cryoablation, whenever we are planning for preoperative medical management to rule out whether it's a clear cell or non-clear cell, whenever there is a high suspicion of unusual pathology requiring radical treatment like sarcomatoid variant or sarcoma. And we should, when to avoid the biopsy, we should avoid the biopsy in all the cystic lesions because the yield is very less, and because of the spillage of the fluid, there is a chances of having seeding of the tumor cells. Now, what about the sensitivity? Initially, it was said that the biopsy sensitivity was less, so it was not offered. But nowadays, from past few years, it has been identified that the accuracy of the sensitivity and specificity of biopsy is up to 99%. So usually it is said that, but still, up to 1/4 of the biopsies may be non-diagnostic. How to comment that whether it's an adequate biopsy? So at least 2 good quality should be obtained, and necrotic area should be avoided. So if there is a less than 2 good quality cores are available, we should consider it as an inadequate sample, and we should try for the rebiopsy. And we should preferably take a peripheral biopsy to avoid any central necrosis. And the best method to do is the coaxial multi-core two-cut biopsy, because it not only gives you a better yield, but also avoid the possibility of seeding of the tumor cell. Now, what is the morbidity? Whenever you are offering any treatment modality or any investigation modality, you should know about that what are the shortcomings. So there is a possibility of subcapsular or perinephric hematoma, and which it can lead to difficulty in the further future at the time of future surgery. And there is definitely a possibility of tumor seeding also. However, this is further less with the coaxial multi-core tube. Now, whenever we have taken the treatment, whenever we have done the treatment, so what all should include in the ideal pathology report? So it should mention about the type and subtype of tumor if there is any. It should mention about the grade. Grade is usually human grading system because it will going to give us about the aggressiveness of the tumor. We should comment over the margin. We should comment over the renal sinus fat, PCS, and vascular invasion. Why it is important? Because these all three includes the T3 disease, and T3 disease is the locally advanced disease. Initially, it was said that whenever you are achieving an R0 resection, even up to T3, there is no need for any adjuvant treatment. But nowadays, there is a recent trial has come which shows that selective high-risk patient can be offered adjuvant treatment. So it is very, very important to comment over this. And whenever we are finding such, getting these findings in the final biopsy, we should always refer the patient to the medical oncologist to take a decision whether patient should be offered adjuvant treatment or not. Because these are the patients who can have a progression or early recurrence, and later on they can crib that why we have not offered them the adjuvant treatment. We should comment over the lymphovascular invasion. We should comment over the necrosis, sarcomatoid variant, any unusual finding, evidence of any thrombus, and zerota and perinephric fat invasion. Now, what are the prognostic factors? So whenever somebody is identified with the RCC, definitely either the patient itself or you yourself will like to see that what is the prognosis, whether we are dealing with a good prognostic tumor or poor prognostic tumor. So what are the things? So there are anatomical factors which include tumor size, venous invasion and extension, collecting system invasion, perinephric and sinus fat invasion, adrenal involvement, lymph node and distant metastasis. Now, there are certain histological features also like grade, subtype, lymphovascular invasion, tumor necrosis, invasion of the collecting system, and rhabdoid and sarcomatoid changes. Why these are important? Because if we are out of that, tumor necrosis and the sarcomatoid variants are the two findings which will going to give you an idea that you should go for upfront lymphadenectomy also in these patients. Now, the baseline characteristics, so the clear cell variety has the best outcome and followed by papillary and chromophobe, and the cancer specific outcome as per these stages. Up in T3 it is 5 to 2% and like that. So the other prognostic factors are the clinical factors, which includes performance status, local symptoms. As I have told you, if the patient is having pain, not due to hydronephrosis or pain, it is very much suggestive of aggressive pathology, cachexia, anemia, platelet count, neutrophil count, lymphocyte count, C-reactive protein, albumin, and neutrophil lymphocyte ratio. There are certain molecular factors which includes carbonic anhydrase, VEGF, HIF, Ki67. These all are for the research purpose and sometimes for some aggressive or unusual pathologies. Now, there are certain prognostical models which are different for the localized and the metastatic disease. For localized disease, there are the UISS, which includes performance status, T classification and classification. Then there is a Lebanovic system, which includes these things, and they are basically for the purpose of the documentation to tell. Initially, these prognostic systems are only available for clear cell carcinoma, but later on in Lebanovic system, they have included the papillary and chromophore tumor also. Now, this is the venous system and grand system. They are basically to predict what we are looking forward, whether patient is an aggressive patient, where we are dealing with aggressive disease or not, and whether how aggressively the patient should offer adjuvant treatment and regular. So there are certain prognostic models for metastatic RCC also, like MSKCC, which includes performance status, interval from diagnosis to treatment, hemoglobin, corrected calcium and LDH level. Now there is an IMDC revised criteria which have started including neutrophil counts also, platelet and other things also. So these are the summary of evidence that what to do and when not to do. So we're going to discuss with this in the analysis. So now what is the treatment? Whenever the patient is coming with an RCC, we have to, main treatment is surgically, because by virtue of its nature, usually it is said that the RCCs are chemo resistant and radio resistant. So whenever we are dealing the treatment, so when we should do, so whenever there are two treatment options available, one is partial nephrectomy and another is radical nephrectomy. Initially, it was said that the partial nephrectomy should be offered in selected patients, but nowadays it is said that you should always try to preserve as much as renal parenchyma. So you should always try to do a partial nephrectomy, provided you are going to achieve few targets, which will not only going to give the advantage to the patient, but also going to avoid certain complications. So what are the goals? So initially, when the partial nephrectomy was devised or introduced, there was trifecta, which includes a warm ischemia time of less than 20 to 25 minutes, negative surgical margin, and no complication beyond clavin grade 3 within 3 months of surgery. But later on, a pentafactor has been involved, which includes other 3 factors like more than 90% preservation of GFR and no stage upgradation of chronic CKD. So these are the 2 things which we have to understand. So whenever we feel that the patient can be off, we can achieve a trifecta or pentafacta, we should always try to offer the partial nephrectomy. If we feel that we are not able to achieve trifecta or pentafacta very efficiently, then in those conditions only the radical nephrectomy should be offered. The initial concept that if the other kidney is normal, or if the patient don't have diabetes and hypertension, so the patient can be offered radical nephrectomy, no, it is not right anymore, because it has been found that even in those cases, the chances of future CKD and future CVS related morbidity is more, and these patients have been identified that they die early because of the CVS or CKD related morbidity rather than the cancer progression. So now what are the factors affecting the pentafacta? So it is the quality of clamping, that how you are clamping the arteries or veins. So whether you are using the Satansky clamp, whether you are using the tourniquet, whether you are using the bulldogs, or even in the bulldogs, whether you are using it with the tip or whether you are using it at the base or U. And it is the timing of the clamping, that what is the warm ischemia time. So if the warm ischemia time will be more, then in that condition, the chances of having CKD will be more. And the quality of the clamping, it also depends that not only that whether it's a continuous or intermittent. We have been seeing that sometime after declamping, if there is a bleeding, we again have a tendency to declamp the vessels, and because of the reperfusion injury, there is always a possibility of more ATN and more chances of CKD. Then it depends upon the quantity of resected normal parenchyma, that how much normal parenchyma we are resected. So if we are taking a less margin, then there is a chances of margin positivity. But if you are taking a more margin, then it will going to sacrifice more renal parenchyma and will going to cause future CKD status. Then the quality of the renography, how we are doing it. So if we are doing it not in an efficient manner, it will going to cause a rim of the renal parenchyma to necrosis, which can eventually lead to CKD. And it also depends upon the location and number of tumor and experience of the surgeon. Now, what are the partial nephrectomy, how to do? So usually it is said that there are 3 approaches: open, lap and robotic. One very important thing is this, that It is not like that the lab is better or robotic is better or open is better. What is better is whether patient require partial nephrectomy or not, and whether you have been able to deliver the partial nephrectomy by achieving the trifecta or pentafecta. If you feel that you are not going to do a partial nephrectomy without achieving the pentafecta in a robotic manner, it is better to go for the open rather than doing an inferior partial nephrectomy by the robotic method. So what is more important is whether you are able to achieve, whether you are able to offer the partial nephrectomy or not, and whether you are able to achieve the pentafecta or trifecta. If you feel that you will not be able to do a robotic partial nephrectomy, or you will not be able to achieve a pentafecta, it is better to offer an open rather than robotic. In long term, it has been identified that except the warm ischemia time and difficulty in doing the surgery, long-term outcomes are same in terms of cancer specific outcome and recurrence-free survival. There is no difference. It is just one of the modality which gives. So what is the significance of ischemia time? So usually it is said that up to 15 to 25 minutes it is safe. Beyond 25 to 40 minutes it is not safe, but it causes renal damage, but usually it is reversible. And but beyond 40 minutes it's irreversible. So it is a time factor related surgery. You should know that doing a partial nephrectomy with a warm ischemia time of 50 minutes or 60 minutes, it is better to do with a laparoscopic approach. So it is better to do a good open partial nephrectomy with less warm ischemia time rather than this. So whenever we are doing a partial nephrectomy, what are the components? So we have to know that we have to take a vascular control first, then we have to resect the tumor, and then we have to reconstruction. So now what are the things? So in vascular control, you can have a non-clamping. Usually it is offered for very small and peripheral tumors which don't have tendency to bleed. And the advantage is less warm ischemia and less future CKD. Now you can have a selective clamping, like if you are having upper pole tumor, instead of putting a clamp over the complete artery, you can just clip the upper pole artery. Then you can have a super selective clamping, which has been very well popularized by one of our Indian surgeon in the Bir Singh Gill. He used to dissect the renal sinus hilum till the time he will going to identify that vessel which is feeding the tumor, and you going to clip it. By that you can have a less bleeding and less global warm ischemia, and which will going to give us a better outcome. Now there is a there is an option of occlusion both renal artery and renal vein. They say that it gives a better blood-free surgical field, and it is easy to treat, easy to do the surgery. Now there is an only renal artery clamping. So now why it is important that only renal artery clamping? Because it has been found that usually the arteries go hand by hand by the side of the renal veins. So what happens if you are not clamping the renal vein? You will be able to identify the venous ooze at the resected margin, and you can take a specific control or suture at that point, and that will going to avoid the chances of missing the arterial arterial cut end of the arteries, and which will going to avoid the future bleeding. And it also going to reduce the possibility of taking a mass closure and causing the compromise of the residual renal parenchyma. Now in one vascular control, one thing is very important, that in cases of the hereditary tumor, when we are expecting the patient may require multiple partial nephrectomy or having more chances of recurrence, in those conditions, instead of doing a dissection in the hilum and taking a control over the renal artery and vein selectively or separately, we should try to do a mass closure, so that in future redo partial nephrectomy, there is a less chances of vascular injury. Now the resection of the tumor, how you can do? You can do a enucleation, you can do a resection, you can do a enucleation and resection, and you can do the with or without cold ischemia. Usually when open surgeries are done, it is usually done with a cold ischemia, but nowadays with the advent of robotic, usually the cold ischemia is not done and the warm ischemia time is less. Now a word about the enucleation. Usually it is said that we should always cut the tumor with the margin of the normal parenchyma to avoid any margin positivity. But those tumors who are centrally placed or in the hilum, there is no renal parenchyma. So in those conditions, or when the patient is having marginal CKD status beforehand, to avoid any future CKD, you can do the enucleation of the tumor also, and it has been found that it has having almost equivalent surgical oncological outcome as with the resection. Now the Renal, how to do the reconstruction, it can be done in single layer or double layer. The advantage of single layer is this, that it take less time, but it going to compromise more normal renal parenchyma. In double layer, it take little extra time, but you can have an early declamping and you can avoid a major renal parenchyma compromise in the later on. The only inner layer has also been defined, which says that you just take a inner layer and leave the outer layer like that, which will going to avoid the further compromise of the renal parenchyma. You can do with or without bolster. It is very important. If you are using the bolster, nowadays nobody use the bolster, but if you are using the bolster, always mention in your OT notes, because sometimes these bolsters give an hyperdense appearance in the follow-up CT scan, and you can confuse whether it's a recurrence or it's a bolster. So if you are using the bolster, you should always try to put it in the OT notes. Now you can do it in a continuous or interrupted manner. You can do with or without hemolox. You can use braided or monofilamentous suture. You can do a mask closure, and you can do a separate closure of PC8 vessels and parenchyma separately. So the purpose of having different things are only to achieve as much as normal renal parenchyma without compromising the oncology scan, and you can confuse whether it's a recurrence or it's a bolster. So if you are using the bolster, you should always try to put it in the OT notes. Now you can do it in a continuous or interrupted manner. You can do with or without hemolox. You can use braided or monofilamentous suture. You can do a mask closure, and you can do a separate closure of PC8 vessels and parenchyma separately. So the purpose of having different things are only to achieve as much as normal renal parenchyma without compromising the oncological outcome. Now the techniques, how to do the declamping. Now, as I've told you, once you are doing a mask closure, you have to do the declamping only after the complete renal. But if you are doing with the multiple layers, then you can do an early declamping, which will going to reduce the warm ischemia time. Now, whether to put the DJs or not, nowadays, because of the magnification and robotic precision, usually we don't put DJs, but yes, whenever there is any doubt that you have opened the major PCS or you have not been able to reconstruct it properly, it is not inferior to put any DJ stand to avoid any major urinary leak. Now the drain, it is mandatory and must, because it is the only tube which will going to give us an idea of early complication like bleeding or urinary leak. Now, is there any role of frozen section? Usually it is said that we should not try to, if you have done a proper surgery, if you are sure that you have not violated the margin, there is no role of frozen section. Because if you want to do the frozen section, you have only two options. Either you have to keep the artery clamped, that will going to increase the warm ischemia time and will going to cause CKD. Or if you will going to declamp it and again going to clamp it, then it will going to cause reperfusion injury and again going to cause the this. So usually if you have not violated any gross tumor margin, or you have not entered in the system, or there is major confusion at the time of surgery, then only you should offer the frozen section, otherwise not. Now, what are the conditions where you have to offer a completion nephrectomy or revision of the partial nephrectomy if margin positive? Now, usually it is not required if in the post-op the focal margin positivity has an equivalent recurrence-free survival time versus no focal margin positivity. So it has been found that if there was no gross violation of the tumor at the time of surgery, and the margin positivity is only focal, and the tumor histopathology is classical and not aggressive, there is no need for having revision of those margin or doing a redo partial or completion partial nephrectomy. However, if there is a gross margin positivity, or if there is any evidence of residual tumor, then in those conditions you can offer redo partial nephrectomy or completion partial nephrectomy. Now the complication, as we know, we are reconstructing three things. We are reconstructing the parenchyma, we are reconstructing the PCS, and we are reconstructing the vessels. So we can have a complication with three. The renal parenchyma reconstruction can lead to renal dysfunction. The vessels can lead to either missing the vessel, leading to excessive bleeding, or in later on it can lead to either aneurysm or AV fistula, which can present as an intermittent hematuria and which will eventually require either angioembolization or redo surgery. Now, in the urinary leak, usually it is said if it is mild and early, then usually it is because of the loosening of the suture, and it usually respond well with the prolonged PUC and drain. If it is moderate and severe but very early, and if you have not put the degestant, then just put the degestant or keep the degestant for a longer duration. And if it is late and associated with any hydronephrosis, then usually it requires PCN placement if there is a focal dilatation or infundibular narrowing or pelvic PUJ narrowing. Now, you have done a partial nephrectomy. When you have to offer the patient to the completion radical nephrectomy? So usually if there is a gross residual tumor is left, if there is a multifocal margin positivity, if there is a residual malignancy present in the follow-up imaging, if there is any abnormal, rare or aggressive pathology, especially the sarcoma or the sarcomatoid variant, or if you find that there is a non-functioning residual kidney, there is no malignancy, but it's not functioning because of some vascular insult, or if there is a persistent bleeding, urinary leak or urinary fistula. These are the candidates where, despite the fact that you have done a successful partial nephrectomy, you have to offer a completion radical nephrectomy in these patients. Now, indication of conversion to radical. So you are attempting a partial nephrectomy when you will going to take a decision or to convert it to the radical on table. So if you find that in the peroperative finding it's a locally advanced RCC, so in these conditions it is better to go for the radical rather than continuing with the partial. If it's a grossly enlarged large nodes which is within very high suspicion of positivity, if there is a high suspicion of abnormal or aggressive pathology, if there is any injury or invasion to the major renal vessels which can lead to major vascular issues leading to non-functioning or poorly functioning in the future, very small residual kidney, like the functioning kidney is very less and it will not going to give any benefit to the patient. If there is any invasion or injury to major renal pelvis leading to obstructive hydronephrosis in the post-op, which can eventually lead to urinary fistula and urinary leak. And last but not the least, if there is an excessive bleeding, always go for the radical nephrectomy to save the life of the patient rather than attempting partial nephrectomy and losing the patient. Now, treatment, as I have offered you, the main treatment indication is surgery. The treatment of choice up to T2 tumor should be very well partial nephrectomy. Beyond T2 tumors, you should not offer partial nephrectomy, but again, it depends upon the experience and the nephrometry scores and the patient prior condition. Now, these are the recommendation. Laparoscopic has lower morbidity, short-term, partial. What is the difference? So basically, it has been found that the robot and the open will going to different mainly in terms of hospital stay, less pain, and early recovery. And long-term outcomes are almost equivalent. So this is the recommendation. Always perform minimal invasive first and all those things. Now, when to do the radical nephrectomy? Again, whenever you feel that you will not be able to achieve a good residual functioning kidney, pentafecta or trifecta, or you will going to compromise with the oncological principles, you should straight away offer the radical nephrectomy. Again, the approach is same: open, lap, and robotic. What are the components? So it's an extraserota excision of the kidney along with the hilar lymph node and upper ureter. Initially, it has been defined with the lymph node from crura of the diaphragm to the bifurcation of the vessels and all those things, but nowadays nobody follows that. So whenever we are doing the radical nephrectomy, whether we can go for resection or excision of adjacent structures, yes. If there is an upper pole tumor and if in the imaging the adrenal is not very much different from that, you can very well go away with the adrenal gland simultaneously. However, if the adrenal is distinct and looks like that it is not involved, you can still leave the adrenal gland. The other adjacent major structures can also be excised, provided you will going to achieve an R0 resection without major morbidity or mortality to the patient. You should not attempt resection of adjacent structures if you are not going to achieve an R0 resection. Now, role of lymph node dissection. Usually in localized RCC, there is no therapeutic benefit. In locally advanced disease, when the tumor is beyond T3, if there is a necrosis, if there is an evidence of sarcomatoid variant, then in these are the patients which are having selective therapeutic advantage in selected patients. There are certain studies which say that there is no advantage. There are certain studies which say there is advantage. That study which says there is no advantage, it's usually a bias study, and it has identified that they have offered only in the high risk patients, which will going to have a poorer outcome. So it has been identified then in the good performance status and low risk patient. And if the lymph nodes are radiologically visible and clinically palpable, then you should always go for the upfront resection, provided you will going to achieve an R0 resection. If you are not achieving an R0 resection, you should not attempt radical, you should not attempt the lymphadenectomy, whether it's a locally advanced or metastatic. Usually in metastatic, again, if you are able to achieve R0 resection, you should definitely go for it. Otherwise, no. Now, any role of neoadjuvant or preoperative medical management? Usually in locally advanced, no. And in localized, there is no benefit at all. In locally advanced tumor, also there is no established benefit. However, it has been identified in certain cases when the tumor burden is more and the patient is require a partial nephrectomy, and we feel that right now going in can lead to a radical nephrectomy. So in these patients, people have tried neoadjuvant treatment or preoperative treatment, and later on able to do a partial nephrectomy rather than doing a radical nephrectomy, or if you are able to make it unresectable to the resectable. But usually the response rate is less than 10 to 15%, and most of the time we have found that the patient has progressed, or else if they have not progressed, then because of the complications of the medical management, they have been identified with the poor wound complication or high wound complication in the post-op. Now, there is a role of cytoreductive nephrectomy in metastatic RCC. Yes, there are two types of cytoreductive nephrectomy. We can go for the partial nephrectomy or complete nephrectomy. Standard of care is complete nephrectomy. However, in selected cases, when the major tumor burden is in the kidney only, and if you feel that doing a radical nephrectomy may make the patient CKD status, and which can later on lead to less options for the medical management, then in these conditions, you can very well offer cytoreductive partial nephrectomy also, but it should be offered in selective patients. Now, before older times, around before a few years back, there was a SWAG trial which shows that there is a definitely advantage of doing a partial cytoreductive nephrectomy in all the patients, completion nephrectomy. But there is a Caramina trial has come which has shown that you should not offer a cytoreductive nephrectomy, but there is a certain bias in that paper. And now it is said that if the patient major tumor burden is in the kidney, if the patient is having some symptoms like bleeding or pain, or if we feel that the patient is not fit for the pre-op medical management, then still in these conditions, you should try to offer a upfront cytoreductive nephrectomy. However, in other patients, you can go for the first medical management, followed by, if the patient is responding well, then you can offer a cytoreductive nephrectomy. Now, what is the role of adjuvant treatment? Usually it is said that the RCCs are chemo and radiation resistant. So in conventional RCC, there is no role of chemotherapy. Definitely there is a role of immunotherapy is there. Usually it is said that initially if you are dealing with a localized or locally advanced tumor, then if you have achieved an R0 resection, there is no need for any adjuvant treatment. But yes, if nowadays it has been identified that in certain high-risk patients, you can offer an adjuvant treatment also to avoid any future recurrence and progression. Now, as far as the radiotherapy, no, usually it is said that there is no role of radiotherapy unless you are giving radiotherapy to the painful bony metastatic site, or you are giving the radiotherapy in those patients who are not fit for the surgery. Initially, it was said that it's a radio-resistant tumor, but nowadays in certain studies, they have come that the SBRT has a role. Now, a word about RCC with the IBC thrombus. So usually the thrombus are two types, the bland thrombus and the tumor thrombus. So how to differentiate? So if it is an enhancing tumor, that means it is with the new vascularization, it's a tumor thrombus. If it is non-enhancing tumor, it's a bland thrombus. Investigation, I have already told you, CT scan is equally effective as MRI. However, if you are having a suspicion of IVC wall invasion, you can go for contrast MRI. Or operatively, you can go for transesophageal echo, and very rarely you can go for vena cavography also. Now, approach. Till now, it was said that the up to level 2 only can be managed minimally invasive method by laparoscopic or robotic, but nowadays even up to level 4 can be very well managed by laparoscopic and robotic approach without compromising the cancer outcome. Now, the technique, Basically, the first and foremost important is the early renal artery control, because that can reduce the extent of the thrombus subcertime, and initially which was an intrahepatic tumor can become a subhepatic tumor, and you can avoid a major vascular suprahepatic control. So our early renal artery control is more important. So if you are dealing with a right renal artery, you can straight away go to the interaortic caval groove, take a control, and will going to give an advantage of having a less bleeding and reduction in the tumor thrombus size up to a certain extent. If you are dealing with the left side, then what you have to do, you have to open a retroperitoneum just lateral to the IMV and make an incision, try to dissect and identify the renal artery and take a control over this. Now, if you are not able to do it, or if you feel that it will be difficult for doing an arterial control in these patients, because that can lead to excessive bleeding, so there is a role of preoperative angioembolization also. But the timing is very important. Usually it is said that you should do embolization in the morning, first half of the day, and do the surgery in the second half, because doing an embolization 24 to 48 hours prior may lead to tumor necrosis factor release, and patient may have fever and other issues which can further complicate the anesthesia. Now, the proximal and distal IVC control, if you are dealing with the level 2 or level 3 thrombus or level 4 thrombus, along with the control of the lumbar vein, because once you will going to you will do a cavotomy, there will be excessive bleeding from the lumbar veins. Now, if you are dealing with whenever you are dealing with the renal vein thrombus, you have to take a control over the opposite renal artery and vein also. And it has, if it is a right side tumor, then in the left side, if you are putting a renal artery clamp, then you can avoid putting a clamp over the renal vein, because it can have a venous drainage through the lumbar vein, and which can decrease the chances of ischemic injury to the opposite kidney. However, if you are dealing with the left tumor, you have to take a control both on the opposite renal artery and vein both. Now, in certain cases, if you are suspecting any early chances of embolization of the tumor thrombus or something, then you can put a pre-op IVC filter also. Now, a word about the excision of the wall. So whenever there is any suspicion of in IVC wall invasion, either preoperatively or peroperatively, you should always excise the wall and consider for the Dacron patch or the graft rather than compromising the outcome. And I will always recommend that you should not hesitate in taking a help of GI surgeon and CVTS support also, especially if you are doing with intra or suprahepatic thrombus. And whenever you are doing cavotomy and repair, always see that there should be no more than 50% narrowing of the IVC lumen. If you are expecting it, it's better to put a graft and reconstruct it rather than leading to other problem in the future. And after that, there is a very high chances of having DVT, so you should have a very good DVT prophylaxis. So this is all about the treatment of locally advanced tumor. As I have told you, that whenever you are able to achieve R0 resection, you can excise all the associated lymph nodes and adjacent structures also. Now, the role of metastatic resection, yes, simultaneous. It should be offered in all patients provided able to achieve an R0 resection, along with no additional increase in morbidity or mortality, including bone and visceral metastasis. Usually, simultaneous resection of liver and brain metastasis should be avoided, because these patients are having poor outcome and it can increase the morbidity. However, once the cytoreductive nephrectomy has been done and if the patient is doing well, then in these conditions, you can have a sequential liver and brain metastatic excision also. And in sequential, if the patient has developed metastatic in the future, or if the patient was having stable brain and liver metastasis after the adequate adjuvant. Now, metastatic resection should be offered only if we are able to achieve an R0 resection. If we are not able to achieve an R0 resection, never offer any metastatic resection. If it will going to provide a symptomatic relief, like in case of bone pain, upper end of the humerus, if there is a metastasis, it is better to excise that, put it an implant, and make the patient R0 resection, make the patient symptom free rather than giving radiotherapy to that area. And if it is not increasing the significant mortality or morbidity, if it is going to do that, never attempt that. Now, therapeutic approaches, alternative to surgery, what you can do in certain patients, if it is a tumor is very small, less than 2 centimeter, patient is elderly, more than 70, 80 years, or having multiple comorbidities, then in that condition, you can have an active surveillance and watchful waiting also because of the slow growth of the tumor. You can do a cryoablation and RFA, but these things you should know that before doing this, there are 2-3 problems. Number one, you will require a preoperative biopsy. Secondly, there is no standard radiological criteria to understand whether the disease is progressing or not. And number three, eventually, if the patient will going to fail to these things, eventually patient will require a surgical intervention, for which patient may not be fit in the later parts. So these things should be offered very cautiously to the high volume centers only, and when the patient is very much supportive and looking forward for a regular follow-up with a good compliance. Now, you can have a stereotactic ablative radiotherapy, you can have microablation, you can have HIFU, and other thermal irreversible electroporation. But these things should be offered very cautiously, should be offered in selected patients. And before offering them, you should know that you should have a biopsy with you and you should be able to follow these patients regularly. So this is all about it. Metastatic part, the medical part, I have not included because I don't think so that it comes under my domain. And yes, there is a very extensive role of medical management nowadays. So if you have any question, you can ask.
Thank you, Dr. Saurabh. There are a few questions in the chat box on the Q&A.
Yeah.
Yeah, Saurabh, both Q&A bhi hai and also in chat box.
So there is one question that there is any specific guideline for neuroendocrine variant of RCC. So yes, whenever you are suspecting neuroendocrine variant, then you should first of all, you should have an preoperative biopsy. Then in the initial evaluation, you have to have a chromogranin assessment. And instead of getting a regular imaging, you should have a functional imaging with a DOTA-NAC scan. And most of the time, it is better to offer them a radical nephrectomy rather than partial nephrectomy.
There are questions in Q&A.
Sir, मैं देख रहा हूँ.
Manish Jethani has asked, sir, what is the difference between clamping and non-clamping in nephrectomy in reducing nephron loss?
Yeah, so basically, if you are taking a control, vascular control, you are putting a clamp or you are occluding the artery and vein, then it is a clamping. If you are not doing if you are resecting the tumor without taking clamping the artery and vein, it is a non-clamping. Usually it is said that the clamp is associated with some warm ischemia time and some irreversible renal damage. So if you are dealing with a very small peripheral tumor where you feel that the bleeding will not be that much, then you can very well offer them non-clamping partial nephrectomy also. However, whenever you should always take a control first. And if there is any doubt of bleeding or anything, it is always better to do a bloodless surgery with a good vascular control rather than having an excessive bleeding and ending up in a radical nephrectomy. So basically, it is related to the warm ischemia type.
Okay. Next question is follow-up post RFA.
So
when do we do the imaging for reassessment?
So I'm not the right person to comment over this. I think the radiology people will be able to better tell them because
usually it is 8 weeks. 8 weeks yes. is when it is the first assessment.
Yes.
Yeah. Next is Sandeep has written, any role to know about the vascular reconstruction when we are offering? If a vascular reconstruction is required, is it contraindication for partial nephrectomy? As long as you can achieve negative margin, still can a vascular reconstruction be done? Say like you go down and there is a polar artery involved at the hilum, but if you can resect and then redo vascular anastomosis, still you can do partial nephrectomy. So can it be done?
It can be done, but usually it is said that it should be done only in selected cases when it's a deemed necessary, like patient is having single artery, patient is having solitary functioning kidney. Usually it has been found that those, if there is a vascular invasion is there, that the patient will come under the category of locally advanced. So even doing a partial nephrectomy in these conditions, patient may have an early chances of recurrence or progression. So it should be offered only when it will not going to compromise the long-term oncological outcome, or if it is deemed necessary, like solitary functioning kidney or patient is having CKD status.
Good. Bammidi Sandeep has asked, sir, before we plan a surgery, opposite side DTPA to prove the kidney is normal, is it mandatory?
Usually, if in the CT scan the opposite kidney is enhancing well, there is no need for having DTPA. Yes, if the patient is having pre-existing CKD status, or then in that condition, it is mandatory to have a GFR assessment of both the kidneys so that you can tell, because sometimes what happens that actually you are operating on a better functioning kidney. And in those conditions, there is a more chances of having high serum creatinine and CKD status, worsening of CKD status. So in that condition, to tell the patient upfront that what is the possibility, it is better. But if the kidney is enhancing well, then there is no need for having preoperative DTPA scan and GFR assessment of the other kidney.
One more question: when should we do renopexy? Suppose you have done a partial, because in first step of partial, full mobilization is done. The kidney is hanging around. So should we do renopexy or we just leave it?
Usually it is said that in the right side it is always